Hello, everyone, and welcome to today's visit together of the Circulation, Arrhythmia, and Electrophysiology Advisory Board on Cardiac Electronic Implanted Devices. My name is Dr. Daniel Morin. I'm from the Ochsner Medical Center in New Orleans, Louisiana, and I'm Senior Consulting Editor for Circulation, Arrhythmia, and Electrophysiology. On behalf of our editor-in-chief, Dr. Paul Wang, who will hopefully be joining us shortly, I'd like to welcome you wholeheartedly. Before I turn this over to our hosts, who are Jordana, Kron, and Theofanie, Mela, who are heads of the advisory board and will be co-hosting our talk today, I'd like to mention that today we're trying something a little bit different, and that is that we are leaving the chat session open. So the chat session on Zoom will be open, and I encourage you, fervently to use that chat session to make any comments and to ask any questions of our presenters or our expert panelists as well. Thank you very much. We will work on getting to any of your questions, and I'm sure this is going to be a fantastic presentation, just as all of the other ones have been as well. So I'll pass it off now to Theofanie or to Jordana, whichever of one of you would like to start off.
All right, I will go first. Thank you so much. Hello, everybody. It is our pleasure to welcome you to our webinar, Prediction of Permanent Pacemaker Implantation After TAVR, Machine Learning Algorithms and Anatomical Predictors. I am Theofanie Mela, an associate professor of medicine at Harvard Medical School and director of the Pacemaker and ICD clinic at MGH in Boston. My co-host tonight is Dr. Jordana Kron, and she's an electrophysiologist and professor of medicine at VCU in Richmond, Virginia.
We are so excited tonight to introduce our fantastic panel of speakers. They are experts in implantable devices, and they're going to help elucidate some of the most recent research on prediction of implantable pacemakers following TAVR. We want to encourage all of you to participate and ask questions using the chat function. It should be a very informal discussion, so please jump in with your questions. There will be time between speakers and at the end with the panelists to ask questions as well.
Our first speaker is Dr. Tsushima. Dr. Tsushima is a PGY-5 cardiovascular medicine fellow and the current associate chief fellow at University Hospitals, Harrington Heart and Vascular Institute and Case Western Reserve University School of Medicine. He received his medical degree from Hirosaki University School of Medicine in Japan and had his internal medicine residency training at University Hospitals, Cleveland Medical Center and Case Western Reserve University School of Medicine. Thank you for being with us tonight, Dr. Tsushima.
Thank you very much for this invitation to this webinar conference. It's so Dr. Morin, Dr. Kron, and Dr. Mela. It's a great honor for me to show our study in this webinar conference. So let me share my PowerPoint with all of you. Are you able to see my PowerPoint?
Yes.
Yes.
That's great.
Okay. So the title of our research was the machine learning algorithm to predict the permanent pacemaker implantation after a transcatheter aortic valve replacement or TAVR. We have no conflict of interest. So the study background is, despite the TAVR is widely utilized for the severe symptomatic aortic stenosis, there is no established risk prediction model of the post-TAVR, the permanent pacemaker implantation at this moment. Machine learning technique is a scientific discipline focusing on the pattern recognition and building the algorithms. Recently, the machine learning is widely utilized for developing the prediction models, especially in the clinical medicine. And the previously reported the machine learning models demonstrated significantly high predictive accuracy compared to the traditional analysis. So here are some sample papers of the machine learning papers. So the objective of this study was to evaluate the performance of the machine learning based algorithm to predict the post-TAVR permanent pacemaker implantation. So the method, here is the study method. This is a single center retrospective study for patients who underwent the TAVR procedure in our single institutions. And the patients who had a pre-existing cardiac implantable electronic device were excluded from this study beforehand. For the machine learning analysis, we used the Waikato environment for the knowledge analysis, or WEKA software, with its version 3.8.3. This is widely available in the internet. In total of the 32 patient variables, such as the patient gender, BMI, coexisting medical comorbidities, electrocardiographic finding prior to the TAVR, echocardiographic information, TAVR procedure technique information, such variables were imported into this software, and the class balancing was performed before testing the 14 different kinds of machine learning classifiers to predict the post-TAVR pacemaker implantation. So here is a study design. Between the 2011 and the 2019, in our institution, a total of the 1,400 patients underwent the TAVR procedure, and we excluded the patients who already had a CIED beforehand. So in total, about the 1,100 patients were finally enrolled to this study, and then entire cohort was divided between a group A and group B. Group A means the derivation cohort, and it has the 890 patients who underwent the TAVR procedure until the 2018. On the other hand, the group B is the external validation cohort. It has the patient sample size as the 270 who underwent the procedure between the 2018 and 2019, just almost 1 year. In each site, the predominantly the indication of the pacemaker implantation was the acute complete heart block, as all of us are very familiar with. And the second indication was the new left bundle branch block with coexisting the first degree AV block or intermittent high degree AV block. In group A, so this is derivation cohort, to evaluate the machine learning analysis technique, we performed the 10-fold cross-validation. So this means in each time, the group A cohort was divided into the 10 small groups. And one of them was named as training data. And the rest of the data was named as the internal validation data. So each time, the machine learning software used the training data to come up with the algorithm or prediction model. And the extracted prediction model was internally validated among the validation data set. And the second time, the training data was switched to the other one and internally validated. So from the beginning toward the end, in the group A, the machine learning software can update and improve the diagnostic accuracy as internal validation. And finally, the finalized algorithm is tested in the group B as external validation. So here is our results. Mainly, we would like to show this figure. It's summarizing the correct classification rate. So the top 3 one in the validation group, simple logistic regression or SLR, locally weighted learner or LWL, and the sequential minimum optimization or SMO. So that these machine learning classifiers showed the best performance or good diagnostic accuracy between 73 and 75% of the accurate prediction of the permanent pacemaker implantation after TAVR. Especially the both SLR and locally weighted learner models achieved the highest area under the curve, or AUC, is reported 0.82. So it's a very good diagnostic prediction. So here is our discussion panel. As first we review the previous literature, there is one article that evaluated the predictive accuracy of the random forest algorithm. This is one of the most commonly widely utilized machine learning classifiers to predict the possibility of the permanent pacemaker implantation after TAVR. So their sample size was 560, and the reported AUC was at 0.81. It's close to our results. Here, we utilized the large patient sample size as 1,000, almost 400, and 14 different machine learning classifiers. The internally and externally validated result supported that the machine learning-based classifiers can predict the post-TAVR permanent pacemaker implantation very accurately. However, SLR, the simple logistic regression, is one of the classical methods, and most machine learning algorithms did not outperform the conventional method in our present study. So such limited result might be associated with the study limitation. First one is that this is a single center retrospective study. The second possible limitation is the indication of the post-TAVR permanent pacemaker implantation was not clearly established in the beginning of our TAVR procedure. So the limited experience may cause unnecessarily pacemaker implantation in the beginning in our institution. The third possible limitation is, so there is the difference of the utilized TAVR valves between the old ones and the latest ones. And also recently, as everybody knows, the indication of the TAVR was widened from this just a severe severe adult cardiogenic surgery patients toward the low risk population. So such the difference of the risk of the adult cardiac surgery, such things might affect the outcome. So here is our conclusion of the study is machine learning algorithm can predict the risk of the post-TAVR pacemaker implantation very accurately, especially the simple logistic regression and the locally weighted learner classifiers achieved the high performance in our study. On the other hand, the currently available machine learning software or algorithm are still imperfect science, so the clinician should use the appropriate classifiers and also software in each setting. So for these reasons, we think the prospective and also the multi-center external validation study should be undertaken in the near future for this most common and interesting clinical topics. This is my last slide. Thank you, everybody.
Thank you for sharing that very exciting data. This is really interesting work. I want to encourage anyone with questions to ask, but I would like to ask, just to kick us off, clinically, how have you used this? Are you using this prediction model with your patients currently? And where do we think this is going in the future? Will we have apps on our phone where we can plug in the data and say, you know, this person's going to need a pacemaker and this person's unlikely to?
I see. Thank you very much for your interesting question. So in our institution, unfortunately, we are not using this study result into our actual practice. Still, all of our electrophysiology attending using the usual techniques, usual considerations, check the patient EKG, following the multiple guidelines from AHA or ACC, but not using this one. We think because our results still have the multiple limitations, but eventually as time goes by, we think the machine learning can tell us the possibility of the pacemaker implantation more rapidly, more quickly and accurately before doing the entire procedure. And it will guide us, especially, I think this topic is very important for patients who have the aortic stenosis with the low risk cardiac surgery, because the open heart cardiac surgery still has the low possibility of requiring the pacemaker, but the TAVR still requires the high possibility. So in this situation, the extracted data, extracted prediction of the pacemaker will guide the both interventional cardiologist and the cardiac surgeon more quickly.
Wonderful. Giuseppe, please ask any questions.
Okay, thank you. I have a question and probably a comment. So first of all, congratulations for this presentation. I think that these results are really important, especially when we tackle TAVR patient, because actually, you know, the prediction of having the need pacemaker is one of the limitations for the early discharge of these patients also. So I think this is very important. But actually, my question is, what about the time window that you use to explore and to adjudicate the pacemaker needs, and then that you use for, you know, the prediction and validation model? This is very important because actually by your data, you missed the diagnosis in 1/3 of patients. Was it related to a different, you know, timing for, you know, adjudicating the need for pacemaker, or what else?
I see. Thank you very much for your important comments and the question. In order to increase the sample size, actually our study was the single center retrospective study. So compared to the other study, we did not limit the timing of the pacemaker. So for instance, not limit like just within the 30 days after TAVR, or within like the 60 days after TAVR. We included all of the pacemaker implantation after TAVR. So everybody will suspect, wait, some of the pacemaker implantation might not be associated with the TAVR procedure itself. So we reviewed the time frame of the pacemaker implantation between the TAVR procedure itself and the exact timing. And actually the 95% of the patients had the pacemaker implantation within the 30 days after TAVR procedure. So we would like to say, yes, a few percent, like a 5% of the patients might have not associated with the TAVR procedure itself, but almost all of them has the device implantation because of the TAVR.
So this is the reason why probably the accuracy was not 95%, because probably if you restrict the analysis to the periprocedural period, I think might be even more accurate, the learning machine process.
I see. Yep, I agree that point. If we do like such more different specific approach with our machine learning software, the extracted result might be different, might be slightly different. So it's a very interesting point.
Thank you. Dan, did you have some comments to make on that?
I do, thanks. So, you know, I, like a lot of other people, I'm excited about the possibilities of machine learning, in particular because some things machines are better than people at, including avoiding bias. However, machines have to, when they're learning, they can only learn from the material or the information that is given to them. Would you tell us and our viewers, what information was fed into the machine learning algorithm so that it could learn from those data in order to put together a prediction model?
I see. Yep. Thank you for your comments. So for instance, for the machine learning, we used the data, especially for the electrocardiogram data. For instance, right bundle branch block, left bundle branch block, first degree AV block, but not actually using the super detailed data. Because for instance, the saying right bundle branch block is the subjective interpretation by the human being, not by the machine learning software itself. So for instance, I think we are still thinking in the future, if we can import such non-objective, the electrocardiographic data, for instance, not saying right bundle branch, left bundle branch, more different method, more different terminology. I think with using these technique, the machine learning approach, machine learning analysis might be improved, but it's still the ongoing topics in our institution.
So were the data that was provided to the computer limited to ECG data, or were there other things like demographics and echocardiography and things along those lines?
Yeah. So in terms of the patient demographics, like the having medical comorbidities, the diabetes, hypertension, these are unchanged. Echocardiographic finding might be more interesting because we only input the data like the maximum velocity, pressure gradient, but just the one topic number. But I think echocardiographic findings is very widened, and we did not include all of the such interesting numbers or informations. So that is very limited point.
Yeah, if I may chime in, I think we basically the input for the function was approximately 14 variables, I think, Taka, right? 14
yes,
variables.
you're right.
Yeah, 14 variables that included clinical comorbidities, demographics, and basic electrocardiographic and echocardiographic parameters, in addition to the type of valve that was used. And we made sure to include only variables that were available prior to the procedure, so that this algorithm can inform, the prediction model can inform the operator and the patient prior to implanting the device.
Thank you for that. I think this is a great first step. And of course, there's going to be all sorts of different kinds of variables that you might be able to add to this in the future and build more on your model. But I don't want to take Fani's time away, but we'll go on to her next.
No, but that's exactly right. So, sorry, I just want to mention a couple of things. You're exactly right on point. Including CT variables. We know there's some literature on where the pattern of the calcification, the morphology of the calcification, the morphology of the valve itself, and also electrocardiography variables. And please tune in to AHA. We're presenting, follow-up work to this month.
So in that same direction, I also wanted to discuss with you so that I can understand of how these models work, the outcome that you chose to look for, which was pacemaker dependency. And you call pacemaker dependency any pacing more than 40%. As a clinical electrophysiologist, I have patients that even with 5% pacing, they go from black, which is syncopal episodes 3-4 times a year, to white, no more syncope in 10 years. So how, in this particular model, but also in general, how do you choose the outcome that you go for, and you are certain that from a clinical point of view is safe and applicable to the practice?
Let me say one thing about it. So the number 40 is not a magic number. So this is coming from the data from David trial. So basically, what we are doing is trying to put something that was proven clinically before to try to discriminate who is going to be more dependent on the pacemaker versus non-dependent. What you say is completely right. There are patients that with very little pacing feel really poorly, and patients that actually pace more do not. But what we have as a strong data from David is that patients that pace more than 40% do worse than patients that pace less than 40%. That's why we use this, not just for this paper, but for other papers from the same research that we publish in other journals. So I think that from a clinical standpoint, that's a valid point to use the 40%.
So we have a question to the presenter and his colleagues from our audience, which is, does this machine learning mode predict late pacemaker implantation, not just immediate post-TAVR?
Thank you for this question. We did not assess the late, in other words, the delayed pacemaker implantation specifically. As I mentioned in the beginning, we included all of the pacemaker implantation. So meaning 95% had the pacemaker within the few days after the pacemaker, but some of them had 1 week later, surprisingly came back to the hospital 10 days later. We included them, but did not do the specific analysis for the late implantation. So we do not have the specific data for this question. Yep.
Great. I thank everybody for their comments. We're going to move on to our second presentation, and then we can carry on with our panel discussion, which I think is going to be really fascinating. So our next speaker is Dr. Luca Fovino, who is an MD, PhD, and an interventional cardiologist at the University of Padova in Italy. So it's very late there in Italy. It's in the 11 o'clock hour, and so hopefully you're still awake drinking some espresso, but we're really delighted to have you join us today. Thank you.
Thank you for the kind invitation. Okay, so let me share my screen. Okay, so on behalf of myself and Professor Tarantini, I would like to thank you for the kind invitation. It's an honor for us to present the results of our paper, which was published in Circa Arrhythmia Electrophysiology previously this year, entitled Anatomical Predictors of Pacemaker Dependency After Transcatheter Aortic Valve Replacement. So we have no conflict of interest to disclose. Just a few seconds of background on the pathophysiology of pacemaker implantation after TAVI. As you know, the conduction system is very close to the virtual buzzer ring, which is the landmark of the target for our for the implantation of our transcatheter aortic prosthesis. As you can see from this anatomical specimen, the virtual buzzer ring is very close to the membranous septum, which is the anatomic landmark for the endocardial surface of the conduction bundle. As you can imagine, when we implant the valve, there is a very close interaction between the prosthesis and these anatomic landmarks. And so there are several types of mechanism of injury during TAVR to the conduction system. There is, of course, the direct compression of the conduction system. There is some kind of hemorrhagic and ischemic injury, also with hematoma, but there is also some reversible, potentially reversible damage, which is caused by inflammation and edema. We just listened to a beautiful presentation about predictors of pacemaker implantation after TAVI, so a lot has been already said about this. But I just want to summarize the fact that these predictors are mostly very well known and very well studied. They are patient related, but also device related. So age, of course, it's a predictor. EKG abnormalities are predictors, in particular right bundle branch block and first degree AV block. But of course, also procedural predictors, such as the valve types, are related to the risk of needing a PM implantation. We know that the self-expandable valves are at higher risk of conduction disorders. New generation valves are at higher risk of conduction disorders because we have the sealing skirt, which was designed to minimize the paravalvular leakage that, have a stronger interaction with the conduction system. And also, of course, very important is the depth of implantation of our valve. Our group, led by Professor Tarantini, published these findings 7 years ago already in Neurointervention about how implantation depth will influence the need for a pacemaker implantation. However, I must say, less is known about pacemaker dependency after TAVI. We know that pacemaker dependency is very high after surgical aortic valve replacement, probably because the surgeon with a stitch of his needle makes a much more durable damage to the conduction system. However, data on PM dependency after TAVR are not as consistent. We have a lower rate of pacemaker dependency at 30 days and 1 year. And this pacemaker dependency rate is highly variable across studies. And it ranges, as you can see from this slide, between 30 and 70%, more or less. Moreover, what is completely missing in the literature are predictors, clinical and anatomic predictors of conduction disturbance persistence, so pacemaker dependency after transcatheter aortic valve replacement. And so these are eagerly needed by the clinicians. So in order to address this gap, we designed these single center retrospective studies in which we analyzed all patients undergoing TAVR with new generation devices. As you can see, over 700 patients treated at our institution between 2014 and 2019. And we looked for patients who underwent pacemaker implantation within 30 days. That's because we wanted to have a data about conduction disturbances and pacemaker implantation related actually to the TAVI procedure. We excluded patients with late pacemaker implantation, so beyond 30 days of follow-up. Of course, we excluded patients who already had a pacemaker and patients undergoing valve-in-valve procedures. As you can see from the slides, at 30 days, less than half of the patients were pacemaker dependent. And to define pacemaker dependency, we used definition that was previously published in the literature on this topic. That is, over 90% of ventricular pacing with complete AV dissociation or presence of an escape rhythm with BPM lower than 50 in patients with AFib. And of course, we looked for all kinds of predictors of pacemaker dependency. We looked for clinical characteristics at baseline, EKG, echocardiographic characteristics, procedural characteristics, post-EKG, post-procedural EKG characteristics, and importantly, and this was never done to our knowledge in the literature, we also carefully looked for possible anatomical predictors of pacemaker dependency at computed tomography imaging evaluation. And that's why we also, an exclusion criteria was when patients did not have a good CT imaging quality in order to evaluate pre-procedural computed tomography data. Talking about this, we concentrated particularly on the membranous septum length, which was a known predictor of pacemaker implantation after TAVI that was previously published in several papers. And particularly, we looked at the relation between the membranous septum and the implantation depth of the prosthesis. That is, as you can see here from this zoom picture, this cartoon, which is superimposed to a real actual CT scan of one of our patients. We wanted to see what was the so-called MSID, which is the difference between the membranous septum and length and the implantation depth, in order to assess the actual direct interaction between the lower part of the stent frame of the valve and the conduction system. What we did was basically look at the CT, pre-procedural CT imaging, and we measured the membranous septum length as the distance between the virtual basal ring, so basically the nadir of the cusp, of the aortic cusp, and the lowest part of the membranous septum, which is basically the beginning of the muscular septum. Then we looked at fluoroscopy, at aortic angiography, which we take after all TAVR transcatheter aortic valve implantations to check for good positioning and the presence of paravalvular leakage. We measured the ID and we correlated these two measurements in order to assess, as I said, the so-called MSID. Very briefly, this is the table 1 of our paper. Baseline characteristics, as you can see, no particular difference in clinical characteristics nor in baseline EKG features, such as prevalence of a right-bundle branch block or a first-degree AV block. No particular difference in echocardiographic findings. No significant higher LVEF in terms of, statistically significant, but not clinically significant difference of left ventricular ejection fraction. But what was different was the presence of LVOT calcification which was more prevalent in pacemaker-dependent patients. And in particular, the location of this classification was more often the part below the left coronary cusp in pacemaker-dependent patients. As I want to underline, the last line of this table is that there was no significant difference in membrane septum length per se between patients with PM dependency versus non-PM dependent patients. Looking at procedural characteristics, a remarkable finding was that, as we already know from the literature, self-expandable valves are at higher risk. We know they are at higher risk of PM implantation, and we also saw that there was a higher prevalence of self-expandable valves among PM-dependent patients. But this most striking finding was that actually the difference, the delta between the membrane septum length and the implantation depth was very significantly different in pacemaker-dependent patients as compared to non-pacemaker-dependent patients. And there was also a difference in intraprocedural atrioventricular block. As you can see, no significant difference in terms of post-procedural electrocardiograms. Putting all this data in first in a univariate and then a multivariate model, what we saw was that the only two independent predictors, however, of pacemaker dependency at 30 days after TAVI were the presence of LVOT calcification under left coronary cusp, and we'll talk in a minute about this, and as we expected, the presence of delta MSID over 3 millimeters. So an implantation depth which was more than 3 millimeters as compared to membrane septum length. So putting this together, basically in a prediction model, what we found among patients undergoing PM implantation was that there were patients at very high risk of PM dependency if they had both risk factors for pacemaker implantation. As you can see, over 80% of pacemaker dependency. On the other hand, we had patients at very low risk of pacemaker dependency after TAVR if they didn't have either of the two high risk features. And as you can see, percentage of pacemaker dependency below 3%. And then, of course, you have all the intermediate risk patients which have either the higher MSID or the presence of the LVOT calcification under the left coronary cusps. Of course, this is a small sample size. The median follow-up time was just 28 months. Patients were at a mean age of 81 years, so quite an old population, but we did not observe a difference in terms at least of mortality between pacemaker-dependent patients and non-pacemaker-dependent patients. But, this as a limitation of the small sample size and the fact that we don't know what will happen when we start treating, as we are doing now, patients at a younger age and with a longer life expectancy. So the limitations, of course, of the study, there are several limitations. It's a single center analysis, it's retrospective, it doesn't have an independent core lab validation, although the intra and inter-observer variability in this measurement was very low. So we were, it's quite easy, and you can have a good accuracy when you, analyze and you take these measurements. Another limitation is the fact that we made a kind of a fusion of two imaging methodology. We use pre-procedural CT and we use angio for the implantation depth. We didn't have a post-procedural CT in most of the patients. Of course, this analysis being single-center needs external validation in larger cohorts and in other groups and other ethnicity also maybe. And of course, the impact of pacemaker dependency, which is quite debated in the literature, however, needs to be further assessed in TAVR patients, especially needs to be assessed in patients at longer follow-up, younger patients, which have a more active lifestyle, also in terms of NIH class and maybe also in a repeat hospitalization for heart failure. So the conclusion of the studies are that less than half of the patients undergoing pacemaker implantation after TAVI are pacemaker dependent at 30 days, and also these results are consistent at 1 year for the available patient with the available follow-up. A deep THV implantation in relation to the membrane septum length and the presence of calcification under the left coronary cusp are the strongest predictors of pacemaker dependency after TAVR. And these results have, in our opinion, clinical applications and implication in our daily practice, because if you have a patient with who needs a pacemaker after TAVI, so we're not talking about a patient who need or don't need a pacemaker implantation. These patients do need a pacemaker implantation. But if you have a pacemaker implantation in a patient who has a low likelihood of atrioventricular conduction recovery, so a high likelihood of pacemaker dependency after TAVR, you are more confident that you might be more quick with pacemaker implantation, and this will reduce hospital stay, will reduce costs. And at the same time, if the same patient has a left ventricular ejection fraction reduction, so systolic dysfunction, you might be more prone to consider this patient for a cardiac resynchronization therapy. On the other side, if you have a patient who needs a pacemaker and has a high likelihood of atrioventricular conduction recovery because he doesn't have any high-risk feature for at least anatomical features for pacemaker dependency, and maybe has AFib, this patient might also be considered, maybe not now, but in the future, for example, for leadless pacemaker implantation. So we think there's a future ahead for this kind of evaluation and clinical implications for the findings of our study. And thank you very much for your attention. And with this, I conclude.
Thank you very much, Dr. Fovino. This was an excellent presentation. I think we are all persuaded now that we're going to be using your risk stratification system. And thank you actually for the last part of your presentation when you discussed the clinical implication, and you helped me understand because this was actually going to be one of my questions. How do you use this risk stratification system in clinical practice? And it seems to me that you're suggesting that we are using it only to really risk stratify the patients who are going to be getting a pacemaker. As a clinician, my problem is before that decision. And I wanted to ask you, did you look at the same parameters for patients who did not receive a pacemaker? What was happening with the calcification under the left coronary cusp, and what was happening with the index?
Okay, thank you so much. It is an excellent question. So we first of all, yes, actually no. So we use these measurements for both. So making this study really, helped us understand also how we should implant this type of prosthesis. Also, as interventional cardiologists, particularly with self-expandable valves, which are known to have a higher incidence of conduction disturbances. So what we try to do now is we try to look at membrane septum length before, of course, the procedure, because now we try really to tailor implantation to the anatomical features of our patient. For example, if we have a patient, since as you know, the membrane septum length is very variable. If you have a patient in which you know that you have a very deep membrane septum, you are more confident that that patient can also tolerate a kind of a little lower implantation of valve. Of course, we wish to implant every valve high. The point is that if you implant a valve high, you risk embolization, which is nothing that you want to avoid. It's better to have a pacemaker implantation than to need a second valve to be implanted because the one pops up. And so doing that, we achieved a reduction rate for pacemaker implantation after self-expandable valves, which now is very close to what we have with the balloon expandable valves. So the first answer is yes, we do use this before putting a pacemaker. However, this study was not aimed to decide in which patients we should put a pacemaker, because for that we have guidelines which are very clear and are pretty much consistent, both the European and the American guidelines. So we think that mostly electrocardiographic characteristics should guide the choice for implanting or not implanting a pacemaker, but which pacemaker to implant and how fast, so how long to wait before implanting a pacemaker. We think that this anatomical feature can help in speeding up the process.
Well, let's go ahead and introduce the other panelists for tonight. Theofanie, do you want to go ahead and introduce Dr. Al-Kindi?
Dr. Alkindy is an attending cardiologist and assistant professor of medicine and radiology at Case Western Reserve University. He directs the cardiovascular phenomics core, which utilizes clinical imaging and omics data for disease prediction.
Great. And in addition, from Dr. Fovino's team, we have Dr. Sergio Thal, an associate professor of medicine at Case Western Reserve University, an electrophysiologist at UH Hospitals in Cleveland, Ohio, and also Dr. Giuseppe Tarantini, associate professor and director of interventional cardiology unit at the University of Padova in Italy, who is a past president of the Italian Society of Interventional Cardiology and the chair of EAPCI, the European Association of Percutaneous Coronary Interventions, Scientific Documents and Initiatives Committee. So we're so delighted to have everyone here, and hopefully we can continue some of these really interesting explorations of some really important, interesting research. So I'll throw out a question. I don't know if there's anyone in the chat who's raised this, but what do you think is the next step in these fields, either with machine learning or with looking more closely at the anatomy? Where do you think we should go next to try to do a better job of not putting pacemakers in TAVR patients who don't need them? But also, one of the things that worries me most is sending someone home thinking they're going to be okay, and then having them come back, as you noted, 7 to 10 days later, and oh, now they really do need a pacemaker. So what kind of research do you think are you either doing or are you hoping to see coming up the pipeline?
Yeah, I can maybe start answering this question. Sorry. Dr. Thal, go ahead.
Well, I mean, I think that the question still requires a clinical answer. I'm not sure that I mean, these predictor models are something very interesting, very attractive, that we all would like to have a way to know for sure who is going to need a pacemaker or not. Unfortunately, none of these predictions are 100% accurate. I mean, we published previously in JACIP our clinical predictor model, and actually I think that's for the daily clinical practice is more useful. At this point, I don't think that the machine learning is ready for prime time use in clinical settings. I think that is a proof of concept, but there is a long way to go before we are able to use machine learning in order to predict which of our patients is going to end up requiring a device. So at this point, we are still depending on the clinical variables. And of course, the clinical variables as a predictor is a good thing. But then there are patients that go beyond our predictions, and patients that we didn't think they will need a device, they may end up needing a device, and vice versa, patients that were clearly high risk for a device and they actually do pretty well after the procedure, and they do not need one. So at this point, I think it's a very interesting field. I think that it needs to be keep going with research and investigating how can we more accurately predict. But still, I think the decision is a purely clinical decision that depends on each patient and see how the patient performs after the valve implant.
I have one question for, your Jordana or Mela or anyone that want to answer. Do you think that we have to change the trigger points for the implantation of pacemaker in this kind of patients? Because probably the criteria to go for definitive pacemaker might be a little different with patients treated with these kind of devices, because we have to consider that sometimes the need to go for pacemaker implantation, considering that the time course of developing this kind of advanced AV block might be, different, might be dispersed along 1 year of follow-up. But actually, in this kind of patient that receive this kind of prosthesis, probably we have to think or probably try to assess in future studies also the role of changing the trigger point to go with pacemaker, probably in some case also in preventive way, because we cannot hold the patient for 10 days in a hospital. Sometimes we need to go for early discharge because of many, many other reasons. So do you have any ideas about this point?
I can go first and just tell you that in both your presentations, your excellent presentations, you kind of assumed that as clinical electrophysiologists, we have standard criteria that we follow to implant these pacemakers. I can tell you we don't. And many times these decisions, of course, are influenced by some recommended criteria. Yes. But most of the times they depend on how conservative the person who makes a decision is, or how cavalier the person that makes the decision, or when was the last time that we had a patient who went home and arrested with complete heart block. So it is very variable, and that's why I think it's difficult to teach machine learning systems, because we don't really have a standard approach to this problem. I think we need to continue to share experience. You made the point earlier, the first presenter, that maybe this needs to be a multi-center effort. I think combining different experiences from different centers, I can tell you we are very conservative in our center, so we're going to probably be in one part of the distribution of the curve, whereas other centers may be more aggressive, sending home patients without pacemakers. We definitely need to continue to collect experience, in my opinion, and opportunities like this, I think, are perfect to talk about this issue.
Because by the paper of Luca and Fovino, etc., as you can see, the pacemaker dependency is about 50%. So it means that sometimes if you are too aggressive, you might implant, a device that is not needed in the patient. So I think we need more data in this direction.
Okay, let me say, the fact that it's not patient dependent doesn't mean that he doesn't need a device. So the fact that it's not patient dependent means that the patient is not be pacing all the time, but a patient may still be needing pacing here and there. So I mean, I don't think we can separate. Yeah. So what we know, and that's again from, I'm sorry that I'm out of reference to our own research. We published before that actually, if you're patient dependent, meaning that you pace more than 40%, that's not patient dependent, but if you pace more than 40%, your risk of developing heart failure actually increased substantially. So we need to, I think that at this point, I completely agree with what was just said, that the decision is clinical and it's patient by patient. But I think that the predictors are useful in knowing who maybe end up needing more pacing than others. And I think the article that was just presented about the anatomical predictors is very interesting, because it's predicting who's going to be more patient dependent. And then we can make decisions based on that. I think these kind of things are very useful, although they are not determining what we do at the bedside with the patient.
I think these clinical issues become even more important as the patients that get TAVRs become younger and healthier. Because when we talk about putting in a pacemaker in somebody 50, that's different than somebody who's 80. and having that device not get infected, not have a lead fracture over the lifetime of that patient, it's a much bigger deal to put a pacemaker in a younger patient. The other thing that I do want to bring up when we talk about the risk of a pacemaker-induced cardiomyopathy, I think another thing that comes up here is the choice of leads, and we have some interventionalists here who this might not be their their best thing to talk about, or the most interesting thing to talk about. But with physiologic pacing, it's sort of interesting of whether we should sort of choose to put physiologic pacing leads, either his bundle or left bundle, in these patients if we think that they're going to have a high burden of pacing. So I didn't know if one of our electrophysiologists wanted to speak to device choice in these patients, or lead choice. Dr. Mela or Dan, I don't know if you wanted to jump in there.
Okay, go ahead, Dan.
Well, I can say that what we've been doing here mostly is we will decide on whether we'll use physiologic pacing, which we do less frequently, especially in the TAVR population, because there's something in the way there, sort of, versus a CRT. Is we'll use sort of typical criteria for whether we should implant those devices or not, whether there's a wide QRS, whether the ejection fraction is low, things along those lines. In a patient with a preserved ejection fraction who we think is going to pace frequently, I think we're more likely to put a dual chamber pacemaker in that patient. But in a patient with even a mildly reduced ejection fraction, less than 50% from the the block HF trial, we would be more likely to put in a CRT device.
But actually, we have to know also, related to the comments of Jordana, there is a paper in circulation that shows that at 5 years of follow-up, so when you go for longer follow-up, there is an interplay, significant interplay between pacemaker dependency and mortality in TAVR patients. So actually, when we tackle a younger patient, I think that these points need to be explored and assessed better, because it might be not trivial at all.
I agree that these are very important points, and as an electrophysiologist, we struggle with these questions all the time. We have a similar approach to try to give to the patient the lead that we think that they will need, but we have had a reasonable number of patients that we had to upgrade their devices to something different 6 months or a year later, depending on the trajectory that the patient took, reducing their ejection fraction, developing heart failure, or if they were doing well, then we would not change the system that we put in the beginning.
Well, I really want to thank everyone for being here with us tonight. Thank you to our expert panelists, to the two wonderful presentations that we saw tonight. We really appreciate your time and your knowledge and spending time with us tonight. We would like to thank Christina Stein, who helps us organize this webinar and does a fantastic job, and also Dr. Wang and Dr. Morin for their leadership and guidance. So thank you to everyone, and thank you for being here with us tonight.
Good night, everyone.
Good night. Thank you.
Bye-bye.
Thank you.